Hello, I'm Dr. Manjit Matharu. I'm a consultant neurologist at the National Hospital for Neurology and Neurosurgery and an associate professor at University College London Queen Square Institute of Neurology in London, UK. I would like to start by thanking the Ehlers-Danlos Society for kindly inviting me to talk to you about orthostatic headaches. This is my disclosure statement. So what is an orthostatic headache? An orthostatic headache is one that occurs when a person assumes the upright position, such as sitting up or standing up. The accompanying headache is usually of a severe intensity and comes on over a short period of time. On lying down flat, the headache either resolves completely or improves significantly over a short period of time. This headache is also known as a positional headache or a postural headache, as change in position or posture lead to a significant change in the intensity of the pain. The term orthostatic headache is not a diagnosis but a symptom. However, it is an important symptom as it gives us a clue about the possible underlying cause of the headache. So what are the possible causes of orthostatic headaches? The two commonest causes of orthostatic headaches are a cerebrospinal fluid leak or postural tachycardia syndrome. A rare cause is cervicogenic headache. A cervicogenic headache occurs when there's an abnormality in the neck. These patients will report that neck movement leads to pain both in the neck and the head. The vast majority of the people who have cervicogenic headache will report that the neck movement leads to pain in any position, regardless of whether they're lying flat or upright. But in a very small minority, the neck movement only leads to a pain in the upright position. In those rare cases, the presentation is with that of an orthostatic headache. However, this is rare, and for the vast majority of patients, this is not really a consideration. We also have a few cases in whom none of the known causes can be identified. So we describe those as idiopathic. For the rest of the talk, I'm going to focus on cerebrospinal fluid leaks and postural tachycardia syndrome. Let's first talk about cerebrospinal fluid leaks. Cerebrospinal fluid, which is abbreviated as CSF, cushions the brain and the spinal cord and is contained within special membranes called meninges. These meninges cover the brain and the spinal cord and contain the CSF around the brain and the spinal cord. When the meninges are damaged, it can allow the CSF to leak into the body and thereby lower the volume and the pressure of the CSF. This change in volume and pressure can allow the position of the brain to drop within the skull and thereby stretch the pain-sensitive structures. The pain-sensitive structures, such as the trigeminal nerve, when they're stretched, will then lead to development of a headache. So when a person assumes the upright position, the CSF drains into the spine. When that happens, the brain then sags within the skull. That leads to stretching of the pain-sensitive structures, and the patient develops a headache. When the patient lies down flat again, the brain is able to return to its normal position as it is now not being dragged down by gravity, and that leads to a resolution of the pain. So that is the mechanism by which a CSF leak is thought to cause a headache. CSF leaks can be iatrogenic, i.e. caused by medical procedures such as a lumbar puncture or an epidural during labor, which can accidentally tear the dura or the meninges. They can also occur due to trauma. Both the iatrogenic causes and the traumatic causes are relatively easy to diagnose, as there's a temporal correlation between the symptoms occurring after either this procedure or a traumatic incident. The challenging ones tend to be the spontaneous ones, which come out of the blue. These are usually referred to as spontaneous intracranial hypotension. Intracranial means within the head, hypotension means low pressure. So what they're referring to is low CSF pressure within the head that has occurred due to a spontaneous cause. For the rest of the lecture, I will focus on spontaneous intracranial hypotension. Spontaneous intracranial hypotension, abbreviated as SIH, is often under-recognized and misdiagnosed. It is reported to occur in approximately 1 in 50,000 of the population, though I suspect that that is an underestimate. In emergency departments, approximately 1 out of 20,000 cases are due to SIH. Patients with SIH are highly disabled. These patients report that they develop a severe headache within a few minutes of being upright. In those scenarios, it is understandable if patients report that they are unable to carry out most of the activities of daily living. Very many of the patients I've looked after will report to me that they're unable to cook their own meals as they develop a severe headache very quickly. Similarly, some people struggle to even have a bath or a shower. I know people who will use bedpans rather than go to a bathroom. It is therefore unsurprising that a lot of patients with orthostatic headaches due to SIH are highly incapacitated. But part of the challenge we've had is that the diagnostic criteria that we've had for SIH have been very variable over the years. And this has then led to very variable treatments and investigations being carried out. And similarly, for the treatments that have been used, the validity of very many of these options is uncertain. To address this, we decided to carry out a comprehensive systematic review of the literature. We looked at all the English language reports of patients that had SIH. We looked at case series that had at least 10 patients. We excluded patients who had iatrogenic or traumatic causes, and we'd excluded any duplicates. The results of our systematic review and meta-analysis were published earlier this year. As you might imagine, this was a huge undertaking. We identified almost 7,000 publications. After we whittled out those that were not relevant to what we were focusing on, we were left with 144 publications. We systematically looked through these publications, trying to identify how patients presented, what investigations were carried out, and what were the treatments that were offered to them. With regard to the clinical presentation, our results showed that the mean age of presentation was 42.5 years. However, there was a very wide range, with children as young as 2 years presenting with SIH. At the other end of the spectrum, an 88-year-old patient presented for the first time with SIH. SIH is more common in females. Almost 2/3 of the patients who suffer from SIH are women. We identified a number of risk factors. Connective tissue disorders, such as Ehlers-Danlos syndrome, were reported in approximately 37% of the patients. We also noted that spinal pathology, such as having a disc prolapse or osteophytes or microspurs, were reported in 43% of the patients. Bariatric surgery had been carried out in 3% of the patients. When these patients had been seen, there had been an average duration of 31 days at presentation. However, there was a huge range between 1 day and almost 20 years at first presentation. The vast majority of the patients who had SIH had a headache, but that was not invariably the case. 3 out of 100 people did not have a headache at presentation. Of the people who had a headache, the vast majority had an orthostatic headache, though a small minority, 8% of those who had a headache, had a non-orthostatic headache. One of the things that stood out about the headache was that the majority of the patients, almost 3/4 of the patients, had pain at the back of the head, which was commoner than what we see in very many of the other headache syndromes. Besides the pain, we also noted that a lot of the symptoms that are often seen in migraines, such as nausea, vomiting, sensitivity to light, or sensitivity to sounds, were reported by these patients. This is often the cause of misdiagnosis, that you can have symptoms that are very similar to those that are present in migraine. The other thing that stood out about patients with CSF leaks was the presence of symptoms that relate either to the ear or the balance center. Very many of these patients reported hearing disturbances, often describing sounds being muffled. They felt dizzy, they had vertigo, a sensation of spinning. They often had tinnitus to go with this. These audiovestibular symptoms can be quite helpful in making the diagnosis in some patients. There are also some rare things that can occur. Patients can have a reduced level of consciousness, can have some movement disorders, or can have overt cognitive problems, almost like a dementia. Fortunately, these are rare. Now, moving on to the diagnosis. In people with an orthostatic headache, doctors will typically rule out a CSF leak before testing for other conditions. So what are the investigations that can be carried out? The most important investigation is an MRI scan. But besides an MRI scan, also a lumbar puncture or a spinal tap can be carried out. A spinal tap, as shown in this picture, involves having the patient lying down flat and then inserting a needle over usually the lumbar spine. The needle gets inserted into the CSF space. And that then allows us to remove some CSF, but also measure the pressure. And the measurement of the pressure can be quite helpful because if there is a CSF leak, then the pressure should be low. The third type of investigation is what we call myelography. That involves doing a lumbar puncture, just of the type I've described, but instead of getting the CSF out to analyze it, in that case, what we do is we inject the dye through the needle in the hope that it is going to travel up or down the spine and leak out wherever the CSF leak is. This involves using special CT scans, MRI scans, or X-rays to obtain detailed imaging of wherever the damage or the abnormality of the leak is. The final investigation I'll mention is the tilt table test, which is really not for a CSF leak, but to rule out POTS. I'll come back to that later on in the investigation, but in essence, what it involves is measuring the heart rate and the blood pressure when the patient is lying flat, and then the table is tilted so that the patient has head up and then head down. And through all of this, the heart rate and the blood pressure are being monitored. And that can help us make a diagnosis of POTS. Now, what did our systematic review identify about these investigations? We noted that there are a number of very characteristic features that are reported in patients with SIH. These features are what we call pachymeningeal enhancement. There's enhancement of the covering of the brain. You can get sagging of the brain that I referred to earlier on as well. A gland called the pituitary gland looks larger than normal. And the brain becomes congested with blood, so you can get large vessels, what we call venous engorgement. What we showed is how frequently these things occur. So for example, the pachymeningeal enhancement shown on this slide occurs in about 3/4 of the patients. Venous engorgement occurs in 57%. Brain sagging occurs in 43%. The pituitary can be enlarged in about 40%, and 35% of the patients can in fact get collections in the brain called subdural hygromas and occasionally subdural hematomas. With the brain sagging, it creates space in the brain, and the fluid then starts leaking into it, and it can then cause a subdural collection. However, one important thing we pointed out was that approximately 20% of the patients who have SIH have a completely normal scan. And the point that we have emphasized to everyone is that having a normal scan does not definitively exclude a diagnosis of a CSF leak. The other investigation that is done commonly is one of imaging the spine. An MRI of the spine can identify a leak in approximately half the patients. A lot of the spinal imaging, though, is myelography, and myelography is done to identify the site of the leak. And what we managed to show was the different kinds of myelographies that can be done and how useful they are at identifying the leak. The important message that comes through in this is there is no investigation that's perfect. Very many of these myelographic techniques will pick up the leak in a substantial proportion of patients, but not in all patients. So even with a specialized scan like a myelogram, the leak can be missed in a significant proportion of patients. What about lumbar punctures? Are they helpful? What we showed in approximately 700 patients is that even in patients who had a proven leak, the lumbar puncture was abnormal only in 2/3 of the patients. In other words, 1/3 of the patients who actually had a CSF leak had completely normal lumbar puncture pressures. And in fact, 3 out of 100 patients had pressures that were slightly elevated. Yeah. Again, this emphasizes the fact that there is no investigation out there that will always give us a diagnosis. Next, we move on to the treatment of CSF leaks. The treatments that are offered depend on the type and location of the hole or the tear, as well as the underlying cause. Some of the common treatments that are used for CSF leaks include conservative treatments and invasive treatments. In terms of the conservative treatments, we advise lifestyle changes. So the lifestyle changes we advise are ensuring that a patient gets bed rest or stays horizontal as much as possible. We advise people to drink plenty of fluids, 2 to 3 liters daily. We ask them to avoid strenuous activities such as lifting heavy weights. When you lift heavy weights, there are large changes of pressure within the brain, and that can worsen a leak. Similarly, we ask people to limit minor straining activities such as coughing and sneezing, which can be quite difficult, but what can be avoided is straining on the toilet or bending over. So straining on the toilet can be avoided by ensuring that people don't become constipated. People can also use abdominal binders for compression. There are a number of medications that are also used. Intravenous or oral caffeine is used. Theophylline, which is a drug that is often used in asthma and is very similar to caffeine, also has been used. And steroids have been advocated as well. With regard to the medications, I must say that the evidence base for using them is very limited. We don't really know whether these actually help. In terms of the invasive treatments, we can do epidural blood patches or what we call fibrin glue patches, as well as surgery. So what are epidural blood patches? This involves drawing blood from the patient and immediately injecting it into the space around the spinal canal called the epidural space. The blood is thought to create a patch around the outer layer of the meninges, which then reduces the loss of CSF. The mechanism of action is not fully understood, but what we do know is that these are effective. And there are 2 types of patches. When the site of the leak is known, then the blood can be injected close to the leak site. We call that a targeted epidural blood patch. When the site of the leak is not known, but we know that a patient does or is highly likely to have a leak, then we carry out a non-targeted blood patch. This involves injecting blood, typically a relatively high volume, more than 20 mils, into the lumbar spine, which is lower down in the spine. So occasionally, the thoracic spine can also be injected. Now, what did our systematic review tell us about these treatments? We looked at conservative treatment, and we noted that approximately 750 patients reported in the literature had conservative treatment. A quarter of these patients reported that conservative treatment had been helpful. The conservative treatments that had been used most commonly were bed rest and hydration, followed by analgesics. Steroids and caffeine had only been used on very rare occasions. So it's very difficult to, in fact, comment about those and their efficacy. The main message that came through was that the number of patients, the proportion of patients who actually improved with bed rest was actually quite low. And the other thing that we noted was that the amount of time that bed rest was advocated was very variable, ranging from 2 weeks to 2 months. For people who are highly disabled, asking them to remain lying in bed for a long period of time is very difficult and challenging, and also runs the risk of causing all sorts of other medical problems, such as developing a DVT or developing something called POTS that I'm going to talk to you about later on. In terms of epidural blood patches, we noted that for any patient who had had the first blood patch, the success rate of that was approximately 60%. We also compared the success rates of targeted blood patches versus non-targeted blood patches. Even though our systematic review showed that they were about the same, there's a built-in bias over here. The patients who generally got a targeted blood patch were those who had failed to respond to a non-targeted blood patch. So this is not a direct comparison of the success of one versus the other, but it's really the success of a targeted blood patch when a non-targeted blood patch has failed. The thing that really stood out for us, though, was that when an epidural blood patch was carried out, the chances of success were increased if the amount of blood injected was relatively high, high being defined as more than 20 mils. Yeah. High volume blood patches were clearly more successful than low volume blood patches. Blood patches are relatively safe There are no serious adverse effects that have been reported after blood patches. There are some minor transient adverse effects reported, such as back pain, radicular pain, tinnitus, paresthesia, numbness, having a slow heart rate, or feeling very dizzy. There are some cases where the blood has actually spread into what we call the subarachnoid space, and this has in fact been reported in about 9% of the patients. Fortunately, there are no long-term sequelae. I have no doubt there are some patients out there who have had significant side effects from epidural blood patches that have simply not been reported in the literature. And I've certainly come across some people who have reported that to me, though this is not actually reported in the literature itself. After a blood patch, if it's successful, you can paradoxically, in fact, get the opposite problem where the pressure in the brain becomes almost too high. The thinking is that a lot of CSF is being produced with the brain trying to catch up with the loss of CSF. And then once the patch is put into place, that CSF production carries on at a high rate and in fact leads to a high pressure before it settles down slowly. We also looked at surgery. There were reports of surgery in approximately 80 patients. However, it was actually very difficult to figure out what the outcomes were like. In a lot of cases, we did not have any long-term outcomes reported in the publications, or conversely, we had publications that reported that all the patients had improved. There's likely to be what we call a reporting bias over here, with clinicians reporting the successes, but not necessarily reporting when things haven't worked out. When patients had a subdural collection, then surgery was carried out in approximately 24% of the patients. Now, I want to move on to a special type of a leak called a CSF venous fistula. When we look at the types of leaks that we have, what we find are that you can have what we call meningeal diverticuli. These are outpouchings on the covering on the brain, on the meninges. And approximately 42% of the leaks occur from those kind of outpouchings. You can just get a straight tear in the dura itself. Yeah? And 27% of the patients who have CSF leaks have it due to dural tears. This special type of a leak is one where the CSF develops a connection with the vein, and the CSF fluid then starts actually draining into the veins. Yeah? And on imaging, on MRI scans, very often you cannot actually see the fluid outside, which is what we're looking for, because it's all being drained away immediately. In about 28% of the patients, the type of leak is never determined. These kind of leaks can all be identified on CT myelography, and there are special types of scans that can be done to identify a CSF venous fistula. Now, there's a publication from Sharving's group in USA where they looked at 60 people who had an orthostatic headache, where the brain scan was completely normal, and where myelography, conventional myelography, was completely normal, and lumbar punctures had only been abnormal in 3 out of the 29 in whom they have been done. When they went on to do these special scans called lateral decubitus digital subtraction myelography, whereby they lie the patient on one side and then on the other side while they're doing the scans, what they found was that in 6 patients out of the 60, approximately 10% of the patients, they were able to identify a CSF venous fistula. There's also been a systematic review just on CSF venous fistulas. This systematic review identified 18 patients who had CSF venous fistulas and reported that the best way to diagnose them is to carry out either CT myelogram, a dynamic CT myelogram, or a digital subtraction myelogram in the lateral decubitus position, i.e. lying on the side. The majority of these lie in the thoracic spine. Epidural blood patches only produce temporary or no relief. However, surgical intervention after they've been diagnosed was successful in all of these patients. Yeah. So we are now increasingly becoming aware that when we cannot identify a leak site, then we should be looking for these CSF venous fistulas. On putting all of this information together, I've outlined over here the management algorithm that we have developed and use at the National Hospital for Neurology and Neurosurgery. In people presenting to us with a persistent orthostatic headache or in whom we suspect that there may be a CSF leak, we will do the tilt table test when appropriate to exclude postural tachycardia syndrome. In all of these patients, we carry out an MRI scan of the head with contrast and an MRI of the whole spine. If we identify a CSF leak, then we first offer a non-targeted high-volume lumbar epidural blood patch. We will repeat that if there's no response to the first one. However, if patients have failed to respond to two of them, we then proceed to doing a myelographic study in the hope that we can identify the site of the leak. If we can identify the site of the leak, then we either do a targeted blood patch or we proceed to surgery if appropriate. In those people in whom we are not able to identify a CSF leak with myelography, we then do the CT myelogram with either lateral decubitus views or we do a digital subtraction myelogram. For those in whom we are able to identify a CSF venous fistula, we then have surgical correction administered for that. Let's now move on to talking about postural tachycardia syndrome. There's a lecture later today on the management of cardiac autonomic dysfunction, in which this will be discussed in further detail. I will therefore only make a brief introduction to the syndrome and mainly focus on the headache aspects. In postural tachycardia syndrome, patients develop orthostatic intolerance. By orthostatic intolerance, we mean that they develop a multitude of symptoms in the upright position, which generally tend to improve when they're lying flat. This seems to correlate with an increase in the heart rate by 30 beats per minute within 10 minutes of assuming the upright position. In people between the ages of 12 and 19 years, the diagnostic criteria require that the heart rate should go up by 40 beats per minute. However, the blood pressure remains normal, and this is illustrated in this figure showing the results of a tilt table test. In the tilt table test, both the heart rate and blood pressure are monitored when the patient is put in the upright position. In people with POTS, the heart rate goes up, as shown here, but the blood pressure remains stable. In the normal situation, the heart rate either remains stable or only goes up slightly, and the blood pressure also remains stable. Patients with POTS report a multitude of symptoms. Some of the symptoms they report are listed over here and include things such as feeling very lightheaded, tiredness, having blurring of vision, syncope, muffled hearing, palpitations, becoming very tremulous, sweating all over, having nausea, feeling breathless, developing pallor, and feeling anxious. Headaches are also a very common manifestation in patients with POTS. The mechanisms at play in POTS are listed over here. I do not propose to discuss them, as I suspect that they will be discussed in detail later on today. So what do we know about headache disorders in POTS? The first thing to note is that hypermobility syndromes are associated with POTS in between a quarter and half the patients. What about the prevalence of headache disorders in POTS? That depends on how the study was done. An international survey reported that half the patients with POTS had headaches. However, in a single center study where the doctors prospectively questioned each patient about headache disorders, they reported that every patient with POTS had a headache disorder as well. In retrospective studies, where they mainly looked at self-reported headaches, about a third of the patients had had a headache. This is still much higher than what is reported in the population, where approximately 15% of the patients will have a significant headache in any 1 year. What are the types of headaches that are reported in POTS? They mainly come down to migraine and orthostatic headaches. Again, the prevalence of migraine depends on how the study was done. A prospective single-center study reported that 96% of the patients had migraine. The retrospective study reported 28% of the patients had migraine, and international survey reported 40% of the patients had migraine. Whichever figure you look at, it is much higher than the population prevalence, which is in the ballpark region of about 15%. When we look at orthostatic headaches in POTS, then the literature suggests that between a third and 2/3 of the patients have got an orthostatic headache. The cause of the orthostatic headache is poorly understood. There are various mechanisms that are postulated, such as a reduction in the volume of CSF and migraine genes, but these are largely speculative and there's very little evidence for them. The main implication for hypermobile patients is that they're prone to developing a CSF leak. They're also prone to developing POTS. One of the treatments we use initially for the management of a CSF leak is bed rest. Bed rest can lead to deconditioning and can unmask POTS. So a difficult issue tends to be that a lot of the patients who are hypermobile, who develop CSF leaks, can then get superimposed POTS. It is therefore important to ensure that both the POTS and the CSF leak are investigated for. And in the main, when we suspect that a patient may have POTS, we tend to manage the POTS before we manage the CSF leak. This is mainly because the management of POTS is largely non-invasive. The investigations are not invasive, and most of the treatments are medications, whereas a lot of the investigations for CSF leaks are invasive, and the treatments certainly tend to be invasive, especially once blood patches and surgery are being considered. With regard to the management of the orthostatic headache secondary to POTS, it is managed just as other symptoms of POTS are. This centers around implementing the lifestyle advice, making sure that patients are drinking loads of fluids, and starting them on drugs. Very many of the patients who have orthostatic headaches due to POTS will have either partial or complete resolution of the orthostatic headaches once the POTS has been managed. However, there's a small group of people who, despite having optimum treatment of the cardiovascular symptoms, will continue to have the POTS headache. This is not very well understood, and we don't really have much of an idea as to how to manage these patients. In summary, orthostatic headaches occur while a patient is standing or sitting upright and improve when they lie down. Only a few conditions can cause orthostatic headaches, most notably a CSF leak and POTS. Some CSF leaks resolve without treatment, whereas others require lifestyle changes, medications, blood patches, or surgical repairs. Treatments for most leaks tend to be successful, but some patients may continue to have symptoms and disability after several treatments. There is no cure for POTS, but people can manage it by making lifestyle changes and taking medications to control blood pressure and volume. If you have an unexplained chronic or a severe headache that changes with position, then I would beseech you to speak to your doctor to have a discussion about the possibility of having a CSF leak or POTS. Thank you very much for your attention.